All right, everybody, welcome to Pharm 1. I'm Nurse Nick. So this is going to be Chapter 13. This is Central Nervous System Stimulants and Related Drugs to CNS Stimulants. All right. I'm a pharmacology instructor, as you guys know, Pharmacology 1, Pharmacology 2. I've also taught Med Surg. I'm an ER nurse, an American Heart Association, ACLS, BLS, and PALS certified instructor as well. All right. So for Chapter 13, Central Nervous System Stimulants and Related Drugs, I really want to ask yourself, what diagnosis do these medications treat? Okay, CNS stimulants are medications that treat ADHD, like methylphenidate or Ritalin for hyperactivity, right? CNS stimulants, like these are positive, they wake you up, right? They get you going. These are medications that also are classified as anorexiants. So people that want to lose weight, that may have a slower metabolic rate, they'll take these medications as well. CNS stimulants are also given for people that have migraines, narcolepsy, and we're going to talk about those things in this section, all right? So when you first start off with chapters, usually a lot of people are like, this is where in the classroom, everybody's like, did you do your homework last week? You need to, some of the main focus topics come out of the initial part of the discussion of the lecture, right? So, Chapter 13 is going to be CNS stimulants. Forgive me, I'm at a loss for words. Don't judge me. It treats multiple diagnoses like ADHD, migraines, narcolepsy, and also weight loss. And then we're going to jump right in. So, CNS activity can be regulated by checks and balances. There can be excitatory and inhibitory neurotransmitters. We already talked about CNS depressants. So going in, this is going to have probably the same role. With CNS depressants, if their medications cause CNS or central nervous system depression, you shouldn't probably take meds that what? Perpetuate those effects, right? So if somebody's taking benzodiazepines for CNS depression, last chapter, they probably shouldn't drink alcohol, take opiates, or anything else, kava, right? Any of those supplements. In this Chapter 13, CNS stimulants, people that are taking these medications should also avoid excitatory things. So if you're taking CNS stimulants, you should avoid taking other stimulants. People that are taking CNS stimulants that increase all this activity, increase heart rate and everything, they probably shouldn't be smoking cigarettes because that also causes vasoconstriction and tachycardia. Or they should avoid caffeine if they're taking stimulants. It's going to add some risk factors there. So the first slide we're going to talk about is going to be ADHD. There's not a lot of slides in this section, but there's a lot to be said, right? I think there's only 24, 25 slides. So ADHD is the most common psychiatric disorder in children. Mainly affects boys more than it does girls. Actually, boys are affected 3 times as much. Primary symptoms of ADHD is going to be inappropriate ability to maintain attention span, concentration, hyperactivity. A lot of people are diagnosed with ADHD. A lot of children have it now, right? So CNS stimulants are going to be medications that treat that. But let's think about that. If your patient's hyperactive, right, and we give a CNS stimulant, which is supposed to help them increase focus, you want to watch them and make sure that they don't lose additional weight with the CNS stimulant on board, all right? But also you should understand with ADHD, what's the therapeutic outcome? So if you're giving a medication to a patient and the parents brought in and everybody's really concerned about legitimate, situations, you're going to say, listen, I gave this CNS stimulant, Ritalin or some kind of amphetamine. We're giving this medication. What's the therapeutic outcome? What am I going to tell mom? I'm giving this medication and the patient should what? They should have increased focus, increased understanding, not be as hyperactive. Right? They'll be able to concentrate on things more. So the next medication next diagnosis we're going to talk about are migraines. So when people have migraines, sometimes they can actually have increased blood flow to their head. So migraines, common type of recurring headache, usually lasting from 4 to 72 hours. And if you see this patient in your room or wherever you're taking care of them at the hospital, know that patient's probably been enduring that migraine or that severe headache for a very long time before they come see you, you know? Because these are people that generally tolerate that pain a little bit more at home, or try to wait for it to pass to actually go spend, a few hours in the emergency department. So typical features of a migraine are going to be pulsatile quality with pain worsening with each pulse. This is a throbbing pain that they discuss. Most commonly unilateral, it's going to be on one side, but it may occur on both sides of the head. And associated symptoms, if they have increased intracranial pressures, this bounding headache, they're going to have nausea, vomiting, photophobia, right? So think about that. Break it down. We're talking about CNS stimulants. We're going to give this to this patient who has a migraine, right? So this patient may have photophobia. When you bring them back to the room after we did the initial triage, how can we prepare the environment for the patient? We could dim the lights. Make sure when you talk to them, start talking lower. Hey, my name's Nick. I'm going to be your nurse. I know you got a migraine. I'm going to try not to be loud. Let them know that you're respecting them and trying to get them better. You know what I mean? So when we're talking about drugs for ADHD and also narcolepsy, which these are all CNS stimulants, repetition's important to me, so you'll hear me repeat things a lot, all right? CNS stimulants are the first line drugs that we give for these diagnoses. Amphetamines, you're going to notice methylphenidate. Actually, some of these words sound like the word amphetamine is in there. Phenidate, amphetamine. You can also give non-amphetamine stimulants like Vyvanse. Vyvanse is a popular drug for treatment of ADHD. Okay, so what do amphetamines do? They stimulate areas of the brain associated with mental alertness. So amphetamines make you way more alert, right? They make you more, just better concentration, more hyperactive, better focused. I don't want to say more hyperactive because ADHD, these people are going to be too hyperactive. CNS effects, they can cause mood elevation, euphoria, increased mental alertness, which is why we give for ADHD, decreased fatigue and drowsiness. So what diagnosis did we talk about that has fatigue and drowsiness? Narcolepsy. And then you can have prolonged wakefulness. These medications are designed to give you energy to make you awake. So what are some considerations do you think exist with these medicines? Maybe you shouldn't take them right before you go to bed, right? I hope you guys are starting to grasp like the big cloud of information that exists with CNS stimulants. A lot of this stuff is routine information that you just, when you gather it all together, it's like, okay, this all makes sense. All right? So the principal drugs used to treat ADHD and narcolepsy, these are going to be, again, amphetamines and non-amphetamine stimulants. Atomoxetine is going to be a non-stimulant drug that's used for ADHD. Other amphetamines that exist are going to be dextroamphetamine. Do you guys recognize amphetamine, CNS stimulant? The word dextroamphetamine has amphetamine in it. You need to correlate those things. And when I think about CNS stimulants, everything is what? Faster, awake, concentrated. You can have amphetamine sulfate, amphetamine aspartate, which is going to be your Adderall, most commonly prescribed for ADHD as well. And then methylphenidate is Ritalin, all right? So this is the first prescription drug indicated for ADHD, but it's also used for narcolepsy because it increases that mental alertness, right? And it does come in extended releases dosage form, which is going to be Ritalin, sustained released, or Concerta. Now, anorexiants is the next slide. So anorexiants, any substance that suppresses appetite. This is going to be like your phentermine. I think there's a weight loss clinic over in Edgewood. Phentermine is a CNS stimulant, okay? It's going to increase your wakefulness and increase energy levels. Actually, it decreases reuptake of fat as well. The anorexiants, so anorexiants are given to treat obesity. Phentermine, methylphenidate, and then also that attenuate at the bottom. So the mechanisms of actions for these medications, they suppress appetite. They increase the body, not the bottles. They increase the body's basal metabolic rate. So basal metabolic rate, what do you think about when you think about metabolic rate? Well, one is energy, how fast things move, but I also think I should start thinking thyroid, because your thyroid is what usually affects your metabolic rate, right? Mobilization of adipose tissue stores. So it moves those stores. It enhances cellular glucose uptake, and it reduces dietary fat absorption. So it reduces the actual dietary fat that you take in. Adverse effects of anorexiants, right? These are going to be similar to most CNS stimulants, okay? Possible elevated blood pressure and heart palpitations. If you're taking CNS stimulants, they're going to increase your metabolic rate. They're going to increase your heart rate. Some of these actually cause vasoconstriction, right? So vasoconstriction. What does vasoconstriction do to your blood pressure? Vasoconstriction, think of yourself as you're full of just like plumbing, pipes and, hoses, rubber hoses everywhere. Some hoses have larger lumens, which are the holes, right? These are your arteries or vessels that are closer to your heart, typically have larger lumens. And then they got smaller, some kind of, you got down to the tiniest capillaries in your skin, whatever it's going to be. So if you're filled with all this pipe system, rubber hose system, and then all of a sudden it vasoconstricts, right? It's full of water, and everything vasoconstricts, and all of a sudden it squeezes. What's that going to do to your blood pressure? Everything, raw water is going to go up, right? It's going to cause hypertension. So now if you have vasodilation and everything kind of opens up, so if your body's made up of all these rubber hoses and pipes and all these different size lumens, and you have vasodilation, then what would that water do in your body? It would go, right? And that's what your blood pressure does. Vasodilation actually causes hypotension, right? So I like to explain what I'm talking about so you understand how it works and how you're going to get some of those adverse effects related to CNS stimulants. But again, always bring it back. We're talking about CNS, central nervous system stimulants. This causes increase in metabolic rate. It causes vasoconstriction. It's going to cause tachycardia, which now let's look at our adverse effects. Adverse effects of anorexiants. These are phentermine, CNS stimulants. Anxiety, agitation, dizziness, headache. Headache is a huge adverse effect when it comes to hypertension. And then also you can have orlistat, and that's more specific with these meds, which are going to be fecal incontinence and oily stools. All right. So phentermine, sympathomimetic, and anorexiant, it's structure related to amphetamines, but it's a little bit different, and it has a much lower abuse potential. Phentermine, again, is an anorexiant that we give to treat what? Obesity, right? You need to understand therapeutic outcomes. Phentermine, if we're giving this medication, you look at your patient, now you have an obese patient. You give them phentermine, the therapeutic outcome for this patient is you will lose weight, right? So moving forward, CNS stimulants, now we're going to talk about anti-migraine drugs, and you do need to recognize these, all right? These do pop up on tests quite a bit. So the triptans, sumatriptan, elatriptan, all the triptans are going to be anti-migraine medications. Again, your patient's primary complaint, they come into the emergency department, they see you. Primary complaint is going to be, I got a migraine. You're going to bring them back into a room and make sure their room is what? Has dim lighting, and you're not going to be yelling, right? You're going to try to talk lower, right? Try to ease some of that pain. So while we're talking about migraines, I do want to talk a little bit about this. So CNS stimulation causes vasoconstriction. Some of these migraine medications actually have caffeine in them. Caffeine causes vasoconstriction. Caffeine is a CNS stimulant. Caffeine can also cause ulcers, whatever. But caffeine is actually given in some of these migraine medications. So in retrospect, what might be happening is you might actually have too much blood flow going to the head. Has anybody ever had like a a caffeine headache or Coke headache or Mountain Dew headache where they haven't had a pop in a while. It's like, man, I'm getting a really bad headache. It's because your body, your vessels are used to a certain amount of vasoconstriction. And then once they open, you have increased intracranial pressure. You have increased pressure in those vessels. It's what causes a headache, right? It's what causes a migraine until they drink another pop and it goes away, right? So we're talking about anti-migraine drugs in the CNS stimulant section of this chapter. If you have increased blood flow, it causes a migraine. I don't know if any of you guys know this. This is a little bit of a side note, but if you take nitro, if somebody takes nitro for their heart, if they're having an attack or something, it causes vasodilation. So it increases circulation. Vasodilation causes hypotension. And it opens up all your vessels, but it also causes your cerebral vessels to open up as well. An adverse effect of nitro is it will cause a headache. If you give nitro to somebody in the hospital, the old ointment on the chest, tab under the tongue, it causes a headache because of the vasodilation. All right, so again, the focus is these anti-migraine medications, they're going to cause vasoconstriction, and that's what's going to, vasoconstriction is going to decrease, help with that headache or that migraine. So you do need to recognize this list of Triptans, Imitrex, these medications. The Triptans are going to be migraine medications. And then there's also going to be Ergot alkaloids. So Ergot alkaloids were the mainstay of treatment for migraine headaches, but they've been replaced by the Triptans for first-line therapy. There's always a new drug that comes along that works better, but sometimes if it don't work as well, they'll say, okay, let's try this. So Ergot alkaloids, this medication down here, it says ergotamine tartrate, ergotamine with caffeine. This is the medication that they'll use to treat migraines. So there's also dihydroergotamine, which is going to be a nasal spray or it's going to be injectable form. Medications are only taken on the onset of migraines. So if you have a patient that comes in for migraines, you're going to give them something, right? You're going to give them the ergotamine or you're going to give them the sumatriptan or whatever triptan medication to help them get that down. And it may have caffeine, and all these medications we give them are CNS stimulants, right? So, what you need to know about these medications is if somebody goes home and we fix their migraine in the hospital and they're prescribed sumatriptan or ergotamine or anything for migraines, listen to this, okay? The most important thing you need to know is they're only going to take these medications with the onset of migraines. So they don't take these medications every day to prevent migraines. When they do take them, if they have a migraine coming on, they'll go ahead and take them. It's going to help them with migraines, and it will also help them prevent migraines in the future. But it's only given for an acute treatment or an acute effect or an exacerbation of it or, an onset. You only take this medication with onset of a migraine. It's not taken regularly. It's not taken daily. And again, if it causes CNS stimulation, if it causes vasoconstriction, as a rule of thumb with CNS stimulants, with all these narcolepsy, ADHD, what do you think is the contraindication for all these CNS stimulants? People that have cardiac histories, people that have history of dysrhythmias. If we're going to give you medications that can cause vasoconstriction or increase your heart rate or CNS stimulation, your heart works off of CNS stimulation, right? It's got its own internal, intrinsic, the SA node, AV node, bundle of His, left and right branches, Purkinje fibers. It's got its own electrical system inside of it. So you need to watch CNS stimulants for people that have a history of cardiac disorders or dysrhythmias. But again, for this slide, with migraines, when do you take migraine medication? Only on onset. Very good. So mechanism of action for the Triptans, they stimulate 5-HT. You can understand all the receptors. They cause vasoconstriction, reducing headache symptoms. They reduce the production of inflammatory neuropeptides. They're abortive therapy for migraines. Ergot alkaloids narrow or constrict the blood vessels in the brains, right? Are you getting all this? Triptans cause vasoconstriction. It can be irritating on injection. You might feel tingling or flushing. So if there's injection with that, tingling and flushing, I will say sometimes you hear the word paresthesia, where you can get numbness or tingling. That's usually related to circulatory problems, okay? Ergot alkaloids, again, when it talks about ergot alkaloids, this is ergotamine. This also causes that vessel constriction. So nausea and vomiting, you want to look out for that. Cold or clammy hands and feet. Muscle pain, dizziness. Sumatriptan, there's a bunch of triptans. You've seen the list just a little while ago. Slight pharmacokinetic differences exist between some of the products, and the effects are mainly comparable overall. So what this slide is saying is all the triptans, the therapeutic effect is we want to give it to treat migraines. But there are some differences that exist slight differences between the medications. Ergotamine still used to treatment preventive migraines, but it's not as frequently used because the triptans are used more often. Dihydroergotamine is going to be the injectable or the nasal spray. I mean, look at the name of that. The name of that is migrainal. Migrainal. I don't know why they put anal at the end of that. It's kind of weird. Migrainal. Nope. So anyway, ergotamine tartrate with caffeine. Everything that's on here, it's got highlighted in red because it's got a different backdrop. You guys know those are going to be important principles for the actual test itself. But the caffeine, ergotamine, these cause that vessel constriction to reduce the headache. So there are some CNS stimulants, right? Because that's what this chapter is about. That's actually given for respiratory depression syndrome, and these are called analeptics. Analeptics. CNS stimulants that treat respiratory function like apnea, right? People, they're just not breathing well. These medications can also treat analeptics in general. The word analeptics, CNS stimulants that treat respiratory apnea, ADHD, and sometimes appetite suppression, which are going to be your anorexiants, right? We know that. But what I want you to be careful is don't confuse the words analeptics with antilipemic. Antilipemic are your lipid drugs, anti-lipid drugs. These are your cholesterol medications, right? And there's also anti-epileptic, which is what we're going to learn in the next chapter, anti-epileptic. So these medications are used less frequently. They are still used for neonatal apnea, right? And listen close to this. This medication, these methylxanthines, if you look at the last slide, methylxanthines like aminophylline and theophylline can be given for neonatal apnea, right? So neonates to help them breathe. You might see a test question on that, so pay close attention to that. So analeptics is just a word that covers all these CNS drugs that work to treat this stuff. But the methylxanthines, this is a CNS stimulant. And specifically, the methylxanthine medications are called aminophylline and theophylline, and they treat neonates with apnea. Okay? So, mechanism of action for analeptics. Analeptics, again, this is the broader term. They stimulate areas of the CNS that control respiration, so they're going to increase breathing. Methylxanthines inhibit phosphodiesterase, leading to the buildup of cyclic and adenosine monophosphate. So they inhibit phosphodiesterase that causes the buildup of CAMP, right? I'm not going to explain all that. CAMP is a natural immune response. But ultimately what this is going to do is the methylxanthines, you got a patient in front of you and you're going to give them a methylxanthine. Now that I'm talking about theophylline and aminophylline, why am I giving this neonate, not this big giant person? Why am I giving this neonate theophylline or aminophylline? I'm giving that medication to help them breathe, and that's the takeaway. Okay. Also, caffeine can be used. Caffeine antagonizes adenosine receptors. Later on, when we talk about code drugs and Pharm 2, adenosine can actually be given to stop your heart and restart it, right? People that have really fast heart rates, adenosine stops your heart rate. So caffeine antagonizes the effect. We got to really think about all these things instead of just listening to the words fly by. Caffeine is a vasoconstrictor. What does caffeine do to your heart rate? What does caffeine do to your energy level? It increases it. Why are we talking about it? Because we're talking about CNS stimulants, right? So it antagonizes adenosine receptors. So caffeine does the opposite and makes things faster. What do you think your adenosine receptors do? They slow things down. Okay? So caffeine also treats migraines, which we already said, because caffeine's also in that ergot alkaloid, which is called ergotamine. Very good. And then also you want to watch for a history of peptic ulcers. If we talk about caffeine, caffeine is a huge contributor to peptic ulcers, right? So it's contraindicated if somebody has an ulcer. Just to jump in there for a second, what's the risk if you have a gastric ulcer? It's the thinning and erosion of the lining of your somewhere in your GI tract. It can create a hole, which will create a bleed. And you could bleed out, you could have GI bleed, and you could die. All right? Not everything ends with death or that quick. I don't want to, joke about the severity. But anyway, caffeine can lead to ulcers. So they're going to be contraindicated when somebody's got PUD, peptic ulcer disease, or something like that. Caffeine, and this is another anoleptic. This is found in over-the-counter drugs like no-dose, right? So no-dose can be given to treat narcolepsy, but back when I was whatever age, I think in the 90s, like no-dose was that gas station trucker drug. It was just full of caffeine and it kept you awake. It's the primary purpose. So if there's a human needs statement, if somebody's excessively taking no-dose, this patient's probably going to have an altered what? An altered need for sleep. They've probably been awake for 2 or 3 days. And do you know what also, if you stay awake for too long, it kind of makes you paranoid, like you think people are after you and stuff? Like these patients come in like doing crystal meth or something like that. Like it really, really affects you if there's excessive use of this. So caffeine, combination prescription, Fioricet. Fioricet is going to be a migraine medication. So you're going to have, it says combination prescription. So you can have 2 drugs in one, and then they give that one pill, and this one's called Fioricet, and it's going to be given for migraine. Or Fiorinel. And then also caffeine exists in food and beverages, which could be obvious. Chocolate is a big source of caffeine, I hope. Use caution in patients with a history of peptic ulcers. Watch for people that have a myocardial infarction. If you don't know what myocardial infarction is, let's break it down for 1 second. Okay, myo is muscle, cardial is heart. So it's the heart muscle infarction. What's the word infarction mean? It's a big giant word. Well, it's not really that big, but it's why I don't know. Infarction means obstruction. It means blockage. It means occlusion. All of these words mean the same. So you got your heart, right? And the actual vessels, your coronary arteries that go around your heart are what perfuse blood. Because the stuff in there that squeezes atrioventricle, that doesn't perfuse the myocardium. So a myocardial infarction is when there's a clot in the vessels, the coronary arteries that surround your heart. You get a clot in there, and it causes ischemia, it causes low oxygen, and it blocks the blood supply, which is what causes a heart attack. It's a myocardial infarction. So a lot of CNS stimulants are going to be contraindicated for people that had significant cardiac history, like myocardial infarction and also dysrhythmias, because if they have a history of myocardial infarction, they got a history of throwing clots, or they probably have some other comorbidity with plaque in their vessels, right? Hyperlipidemia or something like that. If it's going to cause vasoconstriction, constricting the arteries around your heart, what's it going to put you at risk for? It's going to put you at risk for having another myocardial infarction or another dysrhythmia because it's messing with the electric that's going on in your heart. When it comes down to your heart, there's 1 of 2 problems that can happen. It's either going to be plumbing, right, atrioventricle, or it's going to be electric, right? That's the bottom line. It's your plumbing or electric. That's the only 2 things that can happen to your heart, right? Challenge me, ask me, I'll tell you. So moving forward, Nursing implications, drugs for ADHD. Now I'm talking too fast. Drugs for ADHD, last daily dose should be given 46 hours before bedtime. Drugs for ADHD, tell me the name of the drug that we give for ADHD. You guys would say what? Like methylphenidate, this would be Ritalin, something like that, right? These are drugs that are given to increase focus, right? So they're going to cause, I don't want to say hyperactivity, but if it's going to cause increased alertness and wakeness, we should probably wait what? At least 4 to 6 hours before bed. Like, you can't give this right before bedtime. You have to give this dose at least 4 to 6 hours before somebody plans on going to sleep. This medication you want to take on an empty stomach, 30 to 45 minutes before meals. There might be drug holidays. So what's a drug holiday? As we learned, earlier in pharmacology sections with, absorption, metabolism, distribution, but also we talked about drug tolerance, right? You can build up tolerances. There might be times where patients take drug holidays for ADHD medications to make sure they stay effective, right? Okay, let's take a day or two where they're not taking this medication, reduce the amount that's circulating in the system, kind of affects the receptors in your body a little bit. All right, let's, wait a couple days, maybe wait a week or something like that. And this medication can be reintroduced and still be effective again. Should patients do that independently by themselves? Absolutely not. Patients always do that, or at the design or the encouragement of the physician. Don't ever tell a patient like, yeah, you should just take drug holidays, but you don't want to do that. All right. Instruct the parents to keep a journal, monitor the kid's response to the therapy. Well, it's been effective these days. In all of nursing, hypertension, keep a journal of your blood pressure. Hypoxia, keep a journal of what your SpO2 is running, right, for COPD patients. Somebody with ADHD, keep a journal to see if this medication. This is a good planning, right? We talk about the nursing process. This is the portion where we create interventions where people can stay accustomed to taking care of themselves so they don't have to come back and get readmitted for the same thing or have real strong exacerbations of that diagnosis again. All right? And of course, monitor the child for continued physical growth, including height and weight. This is a CNS stimulant. We give these medications as Anorexiants. What do Anorexiants do? They help you lose weight. So if you're given a CNS stimulant, again, methylphenidate, which is Ritalin, you're given these medications to promote concentration in small little hyperactive beings, this might suppress appetite. This might actually cause weight loss. You need to make sure that we're still meeting nutritional demands, especially for young children, right? Because it's going to affect their growth and all that stuff later. So here's an NCLEX question. So a patient is prescribed an anorexiant. Which statement will the nurse include in a patient teaching? So the answer is going to be D, avoid intake of caffeine. So let's look at these. A patient's prescribed an anorexiant, so it's going to be given to obese patients to help them suppress appetite and they lose weight. Which statement will the nurse include in the patient teaching? So take the medication in the evening with your meal? Nope. CNS stimulants, what do? They make you more awake. They increase your metabolic rate. They get you live. They get you jumping. No, don't take it before you're going to go to bed. You will need to take this drug for at least 2 years. Nope, this is not going to be a permanent solution. If you develop a dry mouth, stop taking the drug immediately. If it increases your metabolic rate, what do you think it does for your hydration? It can cause dehydration, right? It can dry you out, right? This can cause anticholinergic effects. Can't see, can't pee, can't spit, can't poop. These are effects that are going to go all through nursing, so you should remember them. Anticholinergic effects, when medications actually dry you out. Can't see, it can cause vision changes, right? Blurred vision because they're dried out. Can't see, can't pee. Decreased urination, dehydration. Can't spit, dry mouth. Can't see, can't pee. Can't spit, can't poop. Can't see, can't pee. Can't spit, can't poop. If you can't have a bowel movement, it's because of dehydration as well, right? But the last thing says, avoid intake of caffeine. If you're taking an anorexiant, this is a CNS stimulant, you should avoid taking other Stimulants. I hope that you guys are hitting, I'm not hitting that hard enough that that's one of the biggest takeaways. It's the same thing as the CNS depressants. If you're taking CNS depressants, don't take other depressants. So, nursing implications for anorexiants. Follow instructions for diet and exercise. Take this medication in the morning. Avoid caffeine. And then also take fat-soluble vitamin supplements might actually be needed. Ergot alkaloids like ergotamine, and we give ergotamine to treat migraines. Ergotamine, you want to watch for chest pain, confusion, slurred speech, vision changes. These need immediate medical attention. If it causes vasoconstriction and you're having risk for like some kind of embolic event, okay, like a stroke, a heart attack, if you have a stroke, slurred speech, all of that stuff, that vasoconstriction puts you at high risk for a circulatory emboli or embolic event, embolus, a clot, obstruction, infarction. All these words mean the same thing. Analeptics, pay close attention to the ABCs because of the patient's diminished sensorium. So ABCs, again, all question nursing. It's either going to be about safety or prioritization. So it's either going to be assessment, ADPI, or it's going to be the ABCs, airway, breathing, circulation. Monitor for your therapeutic response. So this is the breakdown. CNS stimulants, they cause increase in metabolic rate, tachycardia, right? This patient's probably going to feel warm. Their metabolic, everything's speeding up. Anticholinergic effects, dry mouth. Can't see, can't pee, blurred vision, can't pee, decreased urination, which is also called oliguria. Oliguria means low urine, right? And also constipation. Those are adverse effects, but what are the primary therapeutic outcomes? So the therapeutic responses for ADHD, your hyperactive patient should have decreased hyperactivity. They should have increased attention span and concentration. Your anorexiant, who do we give anorexiants to? Who's the patient here? Our anorexiants are going to be for obese people, right? So anorexiants, you're going to have appetite control. You're going to have weight loss. That's a therapeutic outcome. When you create planning, when you create goals, measurable goals, with this medication, how can we check efficacy? We should check their weight. Narcolepsy. Narcolepsy is when your patient what? They sleep too much. And they fall asleep, they feel drowsy, whatever. They should have decreased sleepiness. And then your serotonin agonist, this is decrease in frequency, duration, and severity of migraines, right? Like your ergotamine. Your ergotamine, you're going to have decreased frequency, duration, and severity of your migraines. They're not going to be as bad. That should calm down. And with all of those, you want to monitor for adverse effects. So that's the end of that chapter. Again, this is going to be your Lilly, your RC Lilly 2020 lecture from your in text. If you have questions, please always feel free to get with me, message me on Remind. Just understand, with every section I lecture on, please understand what's the main topic of the chapter, like CNS stimulants. What diagnosis do they treat? What are the therapeutic outcomes? And what are the adverse effects? And I think I hopefully covered that pretty well for you guys today. Thank you guys very much. See you later.